Now we get to start the part about talking about the specifics of our cranial nerve. So let's go ahead and get started on this part. So you've seen this picture before, just a little reminder on where things are. So cranial nerve 1, so we have one nose, we have two eyes. Olfactory nerve, it's purely sensory, it's for smell, it's a chemoreception, you're picking up on chemicals. It passes through the cribriform plate of the ethmoid bone. Make sure you know that that's not an uncommon test question. So cribriform plate, ethmoid bone. Fibers synapse in olfactory bulbs, and the pathway terminates in the primary olfactory cortex, and it is derived from the telencephalon. So remember chapter 2 when we did our tel, di, mesmet, mai, that's the secondary vesicles. They come from the primary vesicles of prom-rom, right? So prosencephalon, mesencephalon, and rhombencephalon. So olfactory, these slides right here are from the Pearson resource. So it's Marib is the author and Pearson is the publisher. And I really like these. They kind of pull it all together. So origin and course, olfactory nerve fibers arise from olfactory sensory neurons located in the olfactory epithelium of nasal cavity and pass through that cribriform plate of the ethmoid bone to synapse in the olfactory bulb. So fibers of olfactory bulb neurons extend posteriorly as the olfactory tract, which runs beneath the frontal lobe. You guys see this in the lab, you've seen it before, to enter the cerebral hemispheres and then terminates in the primary olfactory cortex. Function is purely sensory, so afferent impulses of sense of smell. And clinical testing, you just ask the subject to sniff something, to smell something. Okay? So you can have it fancy and essential oils, or you could have not fancy at all and just coffee or something familiar like chocolate or cinnamon. Homeostatic imbalance, so this is the way these slides are set up. You're going to see origin and course, function, clinical testing, and homeostatic imbalance for each cranial nerve. So a fracture in that ethmoid bone or lesion of the olfactory fibers may result in partial or total loss of smell, a condition as called anosmia. So as you're familiar with, COVID-19, one of the first initial signs for some people was a loss of taste and smell. Other things affect smell as well. So there's the peanut butter smell test, which I don't fully understand, and I don't know that we do in science because I kind of looked around trying to figure it out. But the Alzheimer's peanut butter test. So if you can't smell peanut butter specifically, Google it. It shows up. It even has its own Wikipedia page. If you can't smell peanut butter, sign Alzheimer's. Not quite sure what's going on there. Anyways, just an interesting fact there. So I like this picture here. You could see exactly where that is coming kind of through the ethmoid bone there. Kind of looks like a hairbrush is what I think it looks like, but yeah. So damage here, so anosmia, so the sense of smell, obviously extremely important. Is this an okay thing to eat or not okay to eat? Is this pleasant? Is it not? Is it rotting? And then that sense of smell is going to keep you alive. If you're asleep and your house is on fire, you might not see it. Obviously, you're asleep. You might not hear it. It might not infiltrate your dream that way, but you'll wake up because you smell the smoke is the idea of that picture. You can see the pathway here, so the anatomy of this, you can look and see those blue dotted lines. So looking at the top area there, the olfactory bulb, then tract and trigone. And then looking over to the left, you can see the lateral stria, and then going to the primary olfactory area, and then you can see on the other side as well in red, coming down and crossing over into that anterior stria. You could see the line in green here from this perspective of cranial nerve 1 and going into the amygdaloid body or nucleus. So that amygdala is responsible for emotions, memory according to emotions. One of the things we associate with the amygdala is anxiety. So basically it puts an emotion to a memory so you remember it. So if you liked something or you didn't like something, and you don't necessarily logically have to remember why you liked it, but the amygdala is going to store that quick response for you. And sometimes that can be associated with anxiety. So that's why things like aromatherapy help with anxiety and memory. Another nice pathway here, you could see this in green, and then that kind of lighter, almost kidney bean shaped green area there showing you the cortex for where smell is going. And then these pathways, of course, are going to get a little bit more complex. You could see where that is going in through the nose. Okay, so this picture has a break here at the cribriform plate and is leaking cerebrospinal fluid, so it's kind of an interesting way to picture that. But if you follow the pathway up and into the brain, you could see it going through that stria medullary area, and then the habecular nucleus, and then you could see the pathways down as well, so inferior through the pons, that dorsal longitudinal fasciculus, the habenicicular reticular fibers, and further down into dorsal vagal nucleus. So remember that things like bad smells can make us nauseous, things like that. Okay, so, or a good smell can start off that whole parasympathetic salivatory pathway, so we can start to start that rest and digest. One nose, two eyes. So cranial nerve 2, optic nerves arise from the retinas, which is really a brain tract. So 1 and 2 really are can be considered part of the central nervous system, but for all intents and purposes, when we're answering test questions, cranial nerves in general are peripheral nervous system. So it passes through the optic canals, converge and partially cross over the optic chiasm or chiasma, and that's that crossover that we're going to look at. Optic tracts continue to the thalamus, so remember the switching station where everything but smell goes through, and some books are even going to tell you that smell goes through there as well. But if you have a test question of what modality is the only modality that doesn't go through the thalamus, pick smell. So optic radiation fibers run to the occipital or the visual cortex. We're going to learn that to be Brodmann's area 17. It's purely sensory visual function in the optic nerves, and it's from the diencephalon. And here is the Pearson view, or Pearson view, that's where you take your testing, so that's funny. Anyway, so here's the Pearson Education publisher slide here. Origin and course, you could read that, we just kind of went through that. Function again, and clinical testing, assess vision and visual field with the eye chart, and testing by testing the point at which the person sees the object or a finger moving into your visual field. So you can check peripheral vision this way as well. View the fundus of the eye with the ophthalmoscope, and you'll learn that from Dr. Zhang. To detect papilledema, swelling of the optic disc, and that is the site where the optic nerve leaves the eyeball, so we're actually able to look at that with the ophthalmoscope, which is kind of cool. And examine the optic disc and retinal blood vessels. Homeostatic imbalance, damage to this nerve results in blindness. And we're going to look at a whole pathway of where is the lesion along this pathway here, and it's going to show up as different forms of blindness. So it's going to get a little complex at first, but you'll get it, and we'll go over it a couple of times. So it's an interesting thing that we do. I think it's more in the chapters later on, so visual pathway chapters. Here's another pathway, the green through here, so kind of cruising around through here, and you can see up top the visual eye field, and then the back area there is the primary visual cortex, or Brodmann's 17. So optic nerve coming in, you can see the ciliary ganglion coming. That's efferent, and that is for pupil dilation there. You could see where the green is afferent coming in and blue is efferent for motor functions, not cranial nerve 2. So note that blue is cranial nerve 3 information. The green is cranial nerve 2. Note that pretectal area, tectum being that superior colliculus, is what it's going to be referring to, so that visual reflex. Cranial nerve 2 and 3, so you can see these pathways again. So interestingly, they put inflammation of the optic nerve. If you look at their right eye, optic nerve, so optic neuritis, that's a salient feature of MS. So sometimes that's going to be the first feature for your MS patient. They will lose maybe peripheral vision or have some sort of blurriness in one eye, and you might be the first one that picks up on that. Okay, so optic neuritis is a common first symptom, salient feature of multiple sclerosis. Cranial nerve 2 afferents here. So axons of the ganglion retinal cells, optic nerve, optic chiasm, that's the crossover. Then we call it the optic tract after that. And then we're going to see it synapse there at the lateral geniculate body of the thalamus. And then Brodmann's area 17 in the back is that primary visual cortex. So Brodmann's areas, remember there was this Dr. Brodmann, and he decided to name things in a numbered fashion, not an ordered number fashion if you look at that. We've got 3, 1, 2, we've got 5, we've got 7, all going to be in that post-central gyri area, and then 4 is going to be pre, which is motor. So it's kind of an odd numbered system here, but it's Brodmann's numbers. And in the back, in that posterior aspect there of that occipital lobe, we're looking at that primary visual center, that 17. So it's in green there. So I give you this as one of your resources in your bright space, and we'll look at this when we get into the cerebrum specifically, and we'll look at what all of the different Brodmann's areas do. So just kind of introducing this concept to you here. Thalamus, remember, is that switching station, and if you look at the jelly bean picture there on the left, if you look posterior, you're going to see the green pulvinar, and then these 2 bumps off of the pulvinar there. There's the medial geniculate body, and that's going to be associated with hearing. The lateral geniculate body is going to be associated for the relay of the visual system there. So that was what I was just talking about a couple slides earlier. So here's that thalamic nuclei relay centers. Again, the left there is that lateral geniculate for sight, and then the medial geniculate is for sound. This is what I was talking about, that picture on the right where it gets a little complex on where the lesion is, and we'll go through this when we get into the visual pathway a little bit more in depth in that chapter. So just the idea of depending on where the lesion is, you'll then see it on the right where they can't see in the black there. So like look at B, right anopia. So they can't see from the right side there. So bitemporal hemianopia, that's C. So if you look there at that optic chiasm, if there's an issue there, we're going to see bitemporal, so 2, right? On the temporal aspect of sight, they can't see. So we'll get into what all of that means when the time comes. Just wanted to introduce that to you. So cranial nerve 2 damage, we're going to see any of these things here. So the actual optic nerve, and then chiasm, and then tract and Meyer's loop and radiations all the way back. So we'll see a loss of light reflex. If you can't see it, we can't reflex afterwards. So if 2 isn't working, the reflex for 3 won't be working in that eye either. Cranial nerve 3, ocular motor, so SO4, LR6, all others 3. So not superior oblique, not lateral rectus, but every other eye muscle, including pupillary changes. Cranial nerve 3. So ocular motor, it's in the midbrain. Roots exit the interpeduncular fossa in between the peduncles, travels through the lateral aspect of the cavernous sinus, and the nerve exits through the superior orbital fissure. Origin and course, fibers extend from the ventral midbrain near its junction with the pons and pass through the bony orbit via superior orbital fissure to the eye. Functions, all of your cranial nerve or all of your extraocular eye muscles except for SO4, LR6. And then clinical testing, examine the pupils for size, shape, equality. Test pupillary reflex with a pen light. So both pupils should constrict when illuminated. And test convergence for near vision and subject's ability to follow objects with the eyes, that H test or that Justin Timberlake test that I was showing you guys in that slide before. So oculomotor nerve paralysis, eye cannot be moved up, down, or inward. At rest, the eye rotates laterally or out because actions of the two extrinsic eye muscles not served by cranial nerves, so LR6, are unopposed. Upper eyelid droops, so we call it ptosis, or blepharoptosis, so eyelid drooping, and the person has double vision, diplopia, and trouble focusing on close objects, and you can see the pathway over on the right. LR6, SO4, although there's 3 again, so cranial nerve 3, efferents, motor, all of those muscles there for you to look at. Here's the pathway. I really like these pictures. It really does a good job of illustrating the pathway. Note that it's starting all the way off to the right. If you look just up and middle to that cerebellum, just to give you a viewpoint there. So you can see the Edinger-Westphal nucleus, and you can see ocular motor nucleus and the nerves associated, and the pathways really associated with both. Another pathway. Aneurysm of the right posterior communicating artery, or PCOM, in our circle of Willis picture. So an aneurysm here can cause issues with sight. Okay, so with sight, with pupil, actually, not sight. Sight would be cranial nerve 2. So this would be a problem with the pupil not constricting appropriately. So look at the picture there with the dilated pupil. And where was PCOM? It was there, posterior communicating artery. There's that cavernous sinus, that picture there at the bottom. That's the cavernous sinus 3, 4, cranial nerves 3 and 4, and then V1 and V2. So trigeminal 1, trigeminal 2, but not 3. That's always the test question. And then cranial nerve 6 and internal carotid. So 3, 4, V1, V2, 6, internal carotid. Here's a bigger picture of that cavernous sinus. Note the pituitary gland superior and that internal carotid that's highlighted. Again, it is 3, 4, V1, V2, and 6. It is not V3, and you can see where that dura mater is surrounding it as well. So what I had to do with this is I just had to draw it over and over again. So I would just draw like kind of a crooked triangle and then go 3, 4, V1, V2, 6, internal carotid, pituitary, just over and over again. And then the point of importance, one of the test questions, like I briefly mentioned, it's V3 is not in there. So the entire trigeminal nerve is not part of that cavernous sinus. And if there's issues with the internal carotid, we might see it start to affect those cranial nerves, and note that that cranial nerve 6 is right next to it, so we'd probably see that first. So just keep that in mind for you there. Cranial nerve 3 nuclei, so looking here at the Edinger-Westphal nucleus, and then Edinger-Westphal, also known as accessory ocular motor nucleus, is the parasympathetic preganglion nucleus that innervates the iris sphincter muscle and the ciliary muscle, so pupil constriction. And so you can see that cranial nerve if you look in the picture to the right, so that cranial nerve and the pathway right through that red nucleus. And then you can see substantia nigra as well over there, but that pathway right through the red nucleus, that becomes important when we talk about the Benedict stroke and the fact that red nucleus is involved in cranial nerve 3 symptoms as well. Benedict stroke will involve those. A little more information for you on Edinger-Westphal. You might start to see, basically it's pointing out, it has come to be used to describe two juxtaposed and somewhat intermingled cell groups of the midbrain that differ dramatically in their connectivity and neurochemistry. On one hand, the classically defined Edinger-Westphal is part of the oculomotor complex that is the source of parasympathetic preganglionic motor neuron input to the ciliary ganglion, so pupil constriction, lens accommodation. On the other hand, Edinger-Westphal is applied to a population of centrally projecting neurons involved in sympathetic, consumptive, and stress-related functions. So it's a little confusing. I'm not going to test you on it. Your boards are really not going to test you on it. You want to know Edinger-Westphal, parasympathetic constriction. But if this is of interest to you, I put a paper down there that you can go after it by looking at that paper. Another nice pathway here to kind of look at the afferent and the efferent of what's going on. So just another picture to help your understanding. Another viewpoint here as well with a clearly labeled ciliary ganglion, ciliary nerve, kind of help you out there. And a reminder of our cranial nerve nuclei, so looking again at that Edinger-Westphal up in between the two superior colliculi there. So letting you know where you are. We can see that ocular motor nucleus as well. So it's located in the midbrain at the level of superior colliculus, ventral to that cerebral aqueduct. So if there's inflammation here, that cerebral aqueduct is going to be the thinnest area. So that's going to become inflamed more evident, more readily than anywhere else in the brain because there's just not as much space here. So just the actual physics of not as much space. And then if you look right where that ocular motor nucleus is, right in front of that area. So we see superior colliculus, and then we see the cerebral aqueduct, that whole line. Let me get my marker here. I'm going to go for green here. So the cerebral aqueduct here, and then right in front of it, we see that ocular motor nucleus, and then we see the trochlear nucleus just inferior or caudal to that area as well. And then we see the ocular motor nerve coming out this way here. So understanding that inflammatory picture there is important. So it extends in a column from the posterior edge of the floor of the third ventricle to the trochlear nucleus. More pictures to help you out if you like these pictures. So cranial nerve 3 damage, we'll see what they call lazy eye in layman's term, or external strabismus. We'll see diplopia or double vision. We'll see ptosis or drooping, and mydriasis, the D in there. When I was studying this to memorize it, the D, I would underline that, and that means dilate. D for dilate. Okay, so mydriasis, so the big pupil. This is all going to be ipsilateral. You can probably hear the bikers in the background still. Can't do anything about that. It's still bike week around here, even with the doors closed. Cranial nerve 4, trochlear nerve. So midbrain is where this one is. Remember our rule of 12s. Rootlets exit the dorsum of the brainstem. So this is the only one that it's going to be coming from around the backside. So that's a salient feature when you're looking at how test questions are worded. Okay? Wraps around to the ventral surface from that dorsal side, travels through the lateral aspect of the cavernous sinus. It's GSE, and the nerve exits via superior orbital fissure. Okay? So it's innervating our superior oblique muscle. This is SO4. Okay, it's SO4. So this one is that interesting one that I suggest if you get confused or want more information on it, use the resources that I have specifically for SO4, for the cranial nerve and the eye muscle simulator. It'll help you out if you want to look at that. So the basics here: fibers emerge from dorsal midbrain and course ventrally around the midbrain to enter orbit through superior orbital fissure, along with ocular motor nerves. Function: primarily motor, supply somatomotor fibers. It can carry some proprioceptor fibers as well to the extrinsic eye muscles and superior oblique, the superior oblique, which passes through the pulley-shaped trochlea. Clinical testing, you could test it with cranial nerve 3. Remember, we look down at the finger to our nose. Homeostatic imbalance. Damage to trochlear nerve results in double vision or diplopia and impairs the ability to rotate the eye inferiolaterally, so down and out, but we test it with down and in. Goofy nerve, right? Okay, so this picture here, you can see that substantia nigra area there, that black substance. So looking above there at that trochlear nucleus, note the salient feature of this nerve is that it's the only one coming off from the backside of, or the dorsal side of this area. So everything else is coming off of that kind of front area. This one is dorsal. So you can see the cerebral aqueduct, and you can see that we're at the level of the inferior colliculus. Another couple of cool pictures here. So that's the picture from your book. You could see the periaqueductal gray, or around the aqueduct, right? So that gray area. We associate that with serotonin. You could see the trochlear nucleus in there, so kind of a neat picture. The M is showing you where the medial longitudinal fasciculus is. And then off to the right is that same picture that we just saw, and the middle area is giving you an idea of where we are. And this is that same book for our cranial nerves that's showing the different pathways here. Cranial nerve 4 damage. So note how she is kind of tilting her head to compensate for cranial nerve 4 damage here. So ipsilateral, same side, eyeball drifts upward and slightly out. So we'll see diplopia or double vision. Patient will tilt the head away from the affected side and tuck their chin, trying to compensate for not being able to use this nerve, this muscle really. This is also how we do our neuro rehab. So when we talk about the VOR, or the vestibular ocular reflex, I'll show you that this is one of the things that we do. So if you've come to yoga club, sometimes we do this where we hold our gaze on something, or a drishti, and then we move our head around and try and stay fixed on whatever object that is. So knowing what happens here when it's damaged can help us with neuro rehab. So simple, quick, easy fixes here. Trochlear nerve supplies the superior oblique, so SO4. So it's named for the sling of connective tissue. That's the trochlea, or it means pulley in Latin, through which that tendon of that weird superior oblique muscle passes. So its cell bodies of origin are located on the opposite side, so contralateral trochlear nucleus. It's a small nucleus, only one muscle to supply, and it's really more of a newer order animal nerve and muscle area here. So primitive animals don't have this. So it's thought to be kind of a newer evolutionary, on the evolutionary scale here. Let's see, one muscle to supply. So located at the level of inferior colliculus, where it indents the medial longitudinal fasciculus, or what we call the MLF, and we saw pictures of that already. Fibers leave the nucleus caudally, remember, and that periaqueductal gray, or around that aqueduct. We saw that PAG in the other slides. Then arch posteriorly to decussate or cross over and leave the brainstem at the pons midbrain junction. So this is unique in two respects. So when we see something unique pointed out like that, we want to pay attention to it because we might see test questions that way. It's the only cranial nerve attached to the posterior surface of the brainstem, and it's the only one to originate entirely from the contralateral nucleus. Make sure you know those two features, please. Cranial nerve 5, trigeminal nerve. So it's the largest. We've seen this in the lab. It's really big, right? So on our specimen, we can see 1, 2, and 5. So these fibers extend from the pons to the face. So remember our rule of fours, right? So pons to the face. And what do we remember about this? Touch, pain, temperature of the face. So that sensory of the face, and then chewing, right? So that's the basic we want to memorize. And then the more specifics are on this slide and in the next coming slides here. So forms 3 divisions, so trigemina, right? 3-fold. So we have V1, V2, and V3. So V1 is ophthalmic, V2 is maxillary, and V3 is mandibular. So ophthalmic means eye, right? Maxilla is like your upper jaw, so between your nose and your teeth, that area there where like a mustache would be. Think of that when you think of maxillary. And then the mandibular is the lower jaw area. So as main general sensory nerves of face transmit afferent sensory impulses, touch, pain, temperature, cell bodies of the sensory neurons of all 3 divisions are located in the large trigeminal ganglion. So origin and course, you can see that it's been divided into the 3 sections here, ophthalmic, maxillary, and mandibular vision, or divisions here. Okay. So going back up to the top there, the mandibular division also contains motor fibers that innervate chewing, muscles mastication. Of note, dentists desensitized upper and lower jaws by injecting local anesthetic like Novocaine into the alveolar branch of the maxillary and mandibular divisions of this trigeminal nerve, respectively. So this pain, since this blocks pain transmitting fibers of the teeth and surrounding tissues to be numb. Ophthalmic division, origin, and course. Fibers run from the face to the pons via superior orbital fissure. Maxillary, fibers run from the face to pons via foramen rotundum. Mandibular division, fibers pass through the skull via foramen ovale. So this mnemonic here is SRO, standing room only. Standing being superior orbital fissure, S. And then maxillary rotundum is the room, right? And mandibular is ovale or only. So standing room only, SRO. Okay, superior orbital fissure, rotundum, ovale. Ophthalmic division function conveys sensory impulses from skin of anterior scalp, upper eyelid and nose, and nasal cavity mucosa, cornea, lacrimal gland. What's lacrimal gland? So tears. Okay, lacrimal is tears. Clinical testing, corneal reflex. So touch the cornea with a wisp of cotton and that should make them blink. So we don't really do that much. So trigeminal makes you feel it, and then that's the sensation. And then 7 is going to make you actually blink. So that's part of the blinking reflex there. Maxillary fibers run from the face to the pons via foramen rotundum. So R for room, rotundum. Conveys sensory impulses from nasal mucosa, palate, upper teeth, skin of cheek, upper lip, lower eyelid. Test sensations of pain, touch, and temperature with safety pin and hot and cold objects. Careful with that, though. Mandibular division fiber passes through skull via foramen ovale, conveys sensory impulses from anterior tongue except taste buds, because that's going to be 7 and 9. Lower teeth, skin of chin, temporal region of scalp supplies motor fibers to and carries proprioceptor fibers from muscles of mastication. So chewing, where are you in space, right? Assesses motor branch by asking person to clench your teeth, open mouth against resistance, and move your jaw from side to side. That's how we test it. So with trigeminal nerve, that's going to be the sensation of touch, pain, temperature of your tongue and in your mouth. So when we think about it, I use coffee as an example. So if the coffee's hot and it burns your tongue, it's cranial nerve 5 telling you that. If you put a lot of sugar in your coffee and it tastes sweet, that's cranial nerve 7 at the tip of your tongue and the anterior 2/3 of your tongue telling you that it's sweet. If you didn't put anything in it and it's bitter, that's cranial nerve 9, the bitter back 9. Nice picture of cranial nerve 5 here, and you can see where it is hanging out up at that. If you look up into that kind of bulb area, that trigeminal ganglion, and then you're going to see it go off into 3 directions there, V1, V2, and V3, and then off to the right you can see the motor branches for chewing. We can see it going over to temporalis, the pterygoids, both lateral and medial, and we can see that big masseter muscle, and we can see anterior belly of gastric down there too. Okay, so homeostatic imbalance, we can see it's going to be called trigeminal neuralgia or tic de la Rue. Okay, so make sure that you know those 2 names, AKAs. Okay, so trigeminal neuralgia, also known as tic de la Rue. Okay, so tic being twitch, de la Rue means painful, or dolor, D-O-L-O-R is, remember the cardinal signs of inflammation, dolor, pain. Okay. Caused by inflammation of the trigeminal nerve. Again, this is a common feature with your MS patients, and it can happen with people that don't have MS as well. It's widely considered to produce the most excruciating pain known. Stabbing pain lasts for a few seconds to a few minutes. It can be relentless. It can occur 100 times a day, usually provoked by some sensory stimulus such as brushing your teeth or even a passing breeze hitting the face. In traditional Chinese medicine, we call that wind, right? Wind invasion. But thought to be caused by a loop of artery or vein that compresses the trigeminal nerve near its exit from the brainstem. Analgesics or pain relief and certain meds, anticonvulsants, are only partially effective in severe cases. Surgery relieves the agony either by moving the compressing vessel or destroying the nerve. Nerve destruction results in loss of sensation on that side of the face. I'm going to adjust them. If they're safe to adjust, I'm adjusting. So especially upper cervical, because again, remember where that trigeminal nucleus is going to. So this is why we have an effect on them and why we want to study our anatomy. This is a nice slide that kind of pulls it all together for you. So it is trigeminal nerve, cranial nerve 5, the 3 different branches, ophthalmic, maxillary, mandibular, sometimes just called V1, V2, and V3. And V1 and V2 are sensory only, V3 are sensory and motor. And then you can see again where these are. It's just a nice one to study from, I think. Here's a nice picture for you. You could see that big nerve there is cranial nerve 5. That is the trigeminal nerve. We'll see that in lab again. And it's coming off of the pons. It's a GSA and an SVE. and the nerve exits through those different foramen, that standing room only. General sensory from the face, touch, pain, temperature of the face, we know that, and then muscles of mastication, and those are the muscles there for chewing that you might need to know, not necessarily for my class, but I think it's a common boards question. Muscles of mastication and stress. So what I want to point out here is why do we clench our jaws? What's the gnashing of teeth? Why do dogs growl, right? So it's that pre-programmed stress response, and it's still in us. That dog is growling in order to show you that it's scared and it's ready to attack because it's afraid, and you should probably give it some space. So we clench our teeth, we grind our teeth, maybe just at night, maybe during the day, and we end up with all sorts of TMJ dysfunctions because it's a pre-programmed stress response kind of left over in there from what that dog is doing. So it'd be kind of weird if we did that to people when we were angry at them and kind of growled at them, but we do sometimes, I guess, right? But you want to understand that instead of just adjusting the jaw, which of course adjust the jaw, we're chiropractors, always adjust, always fix alignment, but understand the neurological component behind it as well, and that it's a stress response, and we need to reprogram that stress response with our neuro rehab. So we have to understand how it got there in the first place, what is that stress response, and then what are we going to do? We're going to do cranial nerve exercises ourselves, for ourselves, and also for our patients. We'll teach them how to do these cranial nerve exercises after we've adjusted them. They're relaxed, they're happier, they're safer, they're in less pain, and then we want to support that de-stress response by unwinding or walking back that pre-programmed stress response and letting them know why. Cranial nerve 5 forms a long, almost continuous column of cells that extends from the rostral midbrain to the upper cervical spinal cord. This is why an adjustment is an effective treatment for this. Main sensory nucleus forms an enlargement in this column in the mid-pons, slightly lateral to the trigeminal motor nucleus. Spinal nucleus extends caudally from this level, caudally towards the tail, remember. Mesencephalic trigeminal tract. So peripheral processes of these fibers are distributed through the trigeminal nerve to muscle spindles. So remember muscle spindles, stretch, right? 1A afferents. Muscle spindles in the muscles of mastication, chewing, and some mechanoreceptors of the gums, teeth, and hard palate. So this is a paper here on cervical disc herniation, so we'll be dealing with that a lot as chiropractors, helping people with that. And then what's going on with the trigeminal system? Why is that causing face pain? Why could that cause headaches and neck issues? And the resource is at the bottom of this slide if you'd like this paper. Trigeminal sensory neuropathy may result from a wide variety of factors, including tumors of the trigeminal ganglion or spinal trigeminal tract, demyelinating diseases, connective tissue disorders. Despite a long list of possibilities, the cause often is difficult to establish, and thus many cases are described as idiopathic. Think of the word idiot, comes from that. We don't know. We report an unusual case of trigeminal sensory neuropathy caused by cervical disc herniation of C3, C4. So check that paper out if that's of interest to you. So I threw these slides in here to remind you, if you had a question about muscle spindles, what was that again? I put the star up at the top there to let you know that it's not really pertinent to this chapter specifically. It's just kind of an aside, so you don't have to go hunting back to that info in there. So go through these star slides if you need that. Cranial nerve 5, mesencephalic nucleus and tract up at the top, main sensory nucleus. What else are we seeing here? We're seeing the cerebellar peduncles, the superior cerebellar peduncle and middle cerebellar peduncles. We could see, what else? We see medial lemniscus, that ribbon that the DCML dorsal columns, medial lemniscus. Also spinothalamic is going to share that medial lemniscal pathway up to the thalamus as well. Yep. Cranial nerve 5, chewing, touch, pain, temperature. Just a little chart here to kind of help you out, to organize what we've been talking about. And another picture here to kind of remind you again, so I think we've got it. Some of these are just to kind of give you a different perspective, a different picture. Again, I think these are really interesting to kind of follow from the tract over on the right. So see the cerebellum on the right. So zip across there, zip across that fourth ventricle to the blue area there, and then you can see where that's going. This one, right? So go ahead and draw this one. No, I'm just kidding. It's like super intimidating at first. Just take it piece by piece. Again, start over at the cerebellum, hop on over to, or go over that fourth ventricle into that midbrain pons medulla area, and check out that trigeminal nucleus and then where are all the different pathways going. So kind of a nice perspective there to kind of bring it all together. It's really just like all those other slides kind of superimposed into one. Another pathway here for your mind's eye to kind of picture as you were looking at this. I thought this one was cool because it brings it all the way up into the Brodmann's area. I'm sorry, not Brodmann's. Well, yeah, it's a Brodmann's area. There's always a Brodmann's area in the brain. But homunculus man is what I meant to say. So homunculus man, remember that area of the cortex. So that area up there is for the face. Okay, so trigeminal, crossing over and zipping up and over to the face. So testing for sensation, you'll learn this in your ALS or in your function ALS. Cranial nerve 5 damage. So what are we looking at here? We can see some paralysis of the muscles of mastication or chewing muscles. His jaw is deviating towards the lesion here. Loss of pain and temperature and touch. Loss of the corneal reflex. And then that trigeminal neuralgia, also known as tic de la rue. Blink reflex involves 5 and 7. So 5, you need to feel it with 5, and then 7 is what's going to make you blink. Acoustic neuromas can compress cranial nerve 5, so if they have trigeminal neuralgia or tic de la rue and you're the first one to treat them, send them out for imaging, and we want to make sure that they don't have an acoustic neuroma or something else going on. You can see in this picture here that an acoustic neuroma is that giant purple thing in the center causing an issue at the nerve. Okay, so the blood vessel could be causing an issue. All sorts of things. So make sure you get them the proper imaging and don't just take it on yourself and then tell them to come on back whenever they get that image and that diagnosis. This gentleman has a herpes zoster on his face here on cranial nerve 5. So what this is chickenpox virus and goes and lies dormant in the DRG and then comes out at times of stress. So stress hormones make that herpes zoster virus think that its host is dying, so it sprays out along a dermatome, and it can spray out along that trigeminal nerve as well. So it's kind of it's a really aggressive case right there. Under cranial nerve 6, so abducens nerve. So we're going to see this coming out of the pons area, travels through the medial aspect of the cavernous sinus. So remember cavernous sinus 3, 4, V1, V2, and 6, right next to the carotid. Travels there. Nerve exits through superior orbital fissure, and I highlighted it in pink over here where cranial nerve 6 is, so you can remember. This slide here, origin and course, fibers leave the inferior pons, enter superior orbital fissure to run to the eye. You can see it over there in the picture. Primarily motor is its function, supplies motor fibers to the lateral rectus. This is LR6, okay, so SO4, LR6, AO3. Conveys proprioceptive impulses from the same muscle to the brain. So where are we in space? The eye muscles will help us with that. Clinical testing, test in common with cranial nerve 3 and 4. Really, we're going to do that, follow my finger in that H pattern for this. Homeostatic imbalance. In abducens nerve paralysis, eye cannot be moved laterally because it produces lateral or abduction. So lateral rectus muscle would then be paralyzed. So at rest, the eye would rotate medially. We would call that internal strabismus. Another picture here to kind of give you a visual of it so you could see that abducens nucleus, and then cranial nerve 6 exiting at the pontomedullary junction, and then cruising along kind of near that trigeminal nerve there, and then going up to the lateral rectus muscle out that superior orbital fissure into that lateral rectus muscle, and you can see its relationship to the internal carotid as well. Moving on to cranial nerve 7, facial nerve. Origin and course, fibers issue from the pons, just lateral to abducens nerve, from the last slide there, enter the temporal bone via internal acoustic meatus and run within the bone and through the inner ear cavity before emerging through the stylomastoid foramen. Nerve then courses to the lateral aspect of the face. So its function, it's a mixed nerve, so this is B, both, okay? That are chief motor nerves of the face. 5 major branches, so temporal, zygomatic, think cheekbone, buccal, think cheek, like the fleshy part, mandibular, that lower jaw, and then cervical. Convey motor impulses to skeletal muscles of face, so muscles of facial expression. This is what they're trying to knock out with those Botox treatments, except for chewing muscles served by trigeminal nerves. And transmit proprioceptive, so position sense, impulses from the same muscles to the pons. Transmit parasympathetic, so the autonomic motor impulses to the lacrimal or the tear glands, nasal and palatine glands, and submandibular and sublingual salivary glands. Some of the cell bodies of these parasympathetic motor neurons are in the pteropalatine and submandibular ganglia. So pteropalatine, to me, that sounds like tears. So know that pteropalatine, that's going to be responsible for tears or lacrimation. Submandibular ganglia, that's the submandibular area, that's saliva, that makes sense. Conveys sensory impulses from taste buds of anterior 2/3 of the tongue. Cell bodies of these sensory neurons are in the geniculate ganglia. So remember that geniculate ganglia has to do with taste. Clinical testing, test the anterior 2/3 of the tongue for ability to taste sweet, right? So give them something sweet. That's not the worst test ever, right? Like, can you taste this lollipop or this ice cream? Salty and sour and bitter is more associated with 9, so don't associate that just because this one resource says it. You want to get that test question right, you answer 9 for bitter. Check symmetry of their face. Ask them to close their eyes, smile, whistle, and so on. Assess tearing with ammonia fumes. Don't do that. People think we're weird enough as chiropractors. We don't need to be assessing tearing with ammonia fumes. You can ask them if one side doesn't tear or not. So again, be aware of the area that you're in and that your patient might be Botoxed, and so they might not have symmetry or able to do some of these things, and it's not necessarily because of a cranial nerve problem. Homeostatic imbalance, Bell's palsy. So trigeminal is tic de la rue, T for T, and Bell's palsy is facial. Make sure you memorize that and get that one right on your boards. Somebody's getting that question for your boards. Partial loss of taste sensation. So Bell's palsy, characterized by paralysis of facial muscles on the affected side and partial loss of taste sensation, may develop rapidly overnight, caused by inflamed and swollen facial nerve, possibly due to herpes simplex 1. The lower eyelid droops, we call that ptosis or blepharoptosis. Corner of the mouth will sag, making it difficult to eat or speak normally. Tears can drip continuously from the eye, and the eye cannot be completely closed. Conversely, we could also see dry eye occur as well. They treat it with corticosteroids, and recovery is complete in about 70% of cases. We have other ways to treat that as chironeuros or just chiropractors in general as well. So with this facial nerve palsy here, this Bell's palsy, you want to rule out a stroke, and we'll look at the difference there. So it's eyebrow sparing is a stroke. Facial nerve is going to affect the eyebrows, but I tell everybody all the time, don't let that be your defining factor. If you are the first one to be looking at this patient, have them go into the emergency room. You do not want to bet their life and your career on the fact that it is Bell's palsy and not a stroke. So the lollipops down there are for us to remember the high yield test questions here. So it is sweet 7. Okay, so taste receptors, sweet 7 It's also salty and sour as well, but it's always just associated with sweet. So look at the tongue over there. Everything but bitter is, because bitter is 9, bitter back 9. I thought this was a nice picture to kind of show you the temporal, zygomatic, buccal, mandibular, cervical aspect on where that is as well. So kind of neat. Check that out. Motor innervation, muscles of facial expression, and also stapedius, stylohyoid, the posterior belly of that weird digastric muscle. Parasympathetics, again, to the tears, so lacrimal gland and that pteropalatine ganglion responsible for that tearing. Sublingual and submandibular as well. So the cranial nerve 7 nuclei, it's GSAs going through that spinal trigeminal nucleus. So remember, trigeminal isn't just for trigeminal. It's super tricky that way, right? So we think of it more like a tract, remember? I think of it kind of like that spinothalamic tract. SVA, solitary tract, again, not just one thing, solitary, kind of a misnomer there, right? GBE, superior salivatory nucleus, this makes sense. So 7, saliva, superior saliva, 7 S's, okay? SVE, facial motor nucleus, and then a nice picture there to kind of help you study. So hang out with that for as long as you need to. Make sure you're pausing at any of these pictures if they are helpful to you for your studies, okay? Just another viewpoint here. The pictures are redundant on purpose. Somebody's going to like one of the pictures and somebody's going to like a different one. So that's why that's like that. Another one here for you. You can see the nucleus. So this is a good picture showing lower motor neuron damage here for cranial nerve 7, or what we call Bell's palsy. A stroke would be upper motor neuron lesion, right? So Bell's palsy, lower motor. Bell's palsy is spontaneous, unknown cause, swelling, compression of the nerve at the distal canal. We see the stylomastoid foramen, so that would be paralysis of ipsilateral or same-side muscles of facial expression, and those facial muscles are going to droop, including the eyebrows and the wrinkles in the forehead. They're unable to smile, loss of corneal reflex, because remember 5 is sensation, that, whoa, I need to blink, and then 7 is the actual motor to blink. Unable to close their eyelid. Internal auditory meatus, you'll see paralysis of ipsilateral muscles of facial expression if we have a problem here. Hyperacusis, so this is going to be like they hear things too loudly, basically. So like I had a patient with this and he was older, so my visual cues kept telling me to talk a little louder and a little clearer, and he kept politely shushing me because he had hyperacusis because of this. So I had to talk a lot quieter because the loudness was painful to his ears. So just a normal voice would be painful as well. Loss of anterior 2/3 of the tongue and decreased tears and saliva on the same side. Damage for an upper motor neuron lesion, that would be that stroke. Okay, so cortical bulbar tract, weakening of the contralateral lower half of the face. We call it eyebrow sparing. They can still wrinkle their forehead. Again, I'm not betting their life and my career on that distinction. Okay. Due to cortical bulbar tract having bilateral innervation to muscles in the upper half of the face, but only contralateral innervation to the muscles of the lower half of the face, they can wrinkle their forehead and raise their eyebrows. That's eyebrow sparing. It's unable to smile. We can see the medulla over there. We know it's the medulla because that inferior olivary nucleus, or that kind of wiggly, squiggly lines there at the bottom. Cortical bulbar tract, I threw this slide in here so you could get a visual of what that means. So coming from the brain, so the proper area of homunculus band. So remember, there's a motor homunculus as well. So whatever aspect of the body we're talking about. So it's coming from the face here down into the ability to move. So how do we detect a stroke? So how to spot a stroke fast? So there is a mnemonic for this. You'll see it on billboards, you'll see it at bus stops, you'll see these campaigns every once in a while. How to spot a stroke fast. The mnemonic is FAST. Face, arm, speech, time, tongue. Okay, so face, ask the person to smile. Okay, that's what we were just talking about. What's going on with that? Is it the facial nerve, or is it a stroke? Is it the lower motor neuron lesion, or is it the upper motor neuron lesion? Arms, we call this drift test. You'll bring both of your arms up like that picture has, and then maybe, see how they're supinated there? Maybe one arm starts to drift downward or pronates, or if they start out pronated, one might start to supinate or drift upwards. Any movement that isn't intended is a positive here. Speech, they might have slurred speech or strange speech. Time to call 911. Remember Jo Bolte Taylor? She's a brain researcher and for some reason forgot to call 911 and had to figure out how to call her work and lost precious time and brain power basically because of that. So you want to make sure you're calling 911. The other T that we use is tongue. You have them stick out their tongue. So see how this gentleman has a deviation to one side here? The problem with all of these tests is if they've had a stroke before and they continue to have these deficits, they're gonna continue to show up. And so if we test them again, we don't know if that's old damage or new damage. And what do you do then? I'm sending them out. I don't mind being wrong. Okay, so if they are not having another stroke and I sent them out and they didn't have a stroke, that's really great news. I don't mind being wrong that way. But if they are having a stroke and I don't catch that it's acute symptoms and I think they're just the old symptoms, or I think it's Bell's palsy instead, and we don't catch that, that's a terrible way to be wrong. Okay, so one of the things I teach is we're going to be wrong as doctors, so just get over it, and it's a very freeing thought, actually. But the idea is, how do I want to be wrong? I want to err on the side of caution is what that means. Okay, so I want to make sure that they're okay. So you want to be able to sleep at night, you want your patient to be well taken care of, and you want to be able to explain yourself to their family members, to their loved ones, on why you did what you did. Okay? Moving on to cranial nerve 8, vestibular cochlear nerve. So vestibular being the balance part, cochlear being the hearing part. The kid down there has a cochlear implant, so he's able to hear where he was not able to hear before. Afferent fibers from hearing receptors of the cochlear division and equilibrium receptors for the vestibular division pass from our inner ear through that internal acoustic meatus and enter the brainstem at the pons medullary border. So it's mostly sensory function, small motor component for adjustment of some of these sensory receptors. We used to just call it the auditory nerve, but we now know that it has a lot of vestibular function. So it's at the pons, we see SSA, hearing in equilibrium, and exiting through that internal acoustic meatus. We can see the picture here. This one has an acoustic neuroma as well. So damage here, we might get tinnitus or ringing of the ears, vertigo, or this kind of spinny, dizzy feeling. Hearing loss can be conduction or sensorineural. So remember our Rins versus Weber test with the tuning fork. Meniere's disease, which is this kind of screechy tinnitus plus hearing loss plus vertigo, kind of debilitating stuff. And we can see that acoustic neuroma there. So OMA, remember, just means tumor or mass of, and so this is nerve tumor. So the review slide here that kind of ties it all together for vestibular cochlear nerve. So the origin and course, fibers arise from hearing and equilibrium apparatus located within the inner ear of the temporal bone, pass through the internal acoustic meatus to enter the brain stem at the pons medullary border. Afferent, so sensory fibers from hearing receptors in the cochlea, form the cochlear division. Those from equilibrium receptors in semicircular canals and vestibular form the vestibular division. We'll get into the vestibular system as a whole PowerPoint in and of itself, so we'll talk about the semicircular canals and make that a whole lot clearer because that's an important aspect of neuro rehab. The two divisions here merge to form the vestibular cochlear nerve. Functions, mostly sensory. Vestibular branch transmits afferent impulses for sense of equilibrium or balance, and sensory nerve cell bodies are located in the vestibular ganglia. Cochlear branch transmits afferent impulses for sense of hearing, and sensory nerve cell bodies are located in the spiral ganglion within the cochlea. So spiral ganglion, cochlea. Small motor component adjusts the sensitivity of sensory receptors. So the clinical testing, check for hearing by air and bone conduction using a tuning fork. So you'll learn Weber's and Rins test. in your physical exam lab. If they're having major hearing issues, though, send them out to someone that actually does that and only that all day, every day. Homeostatic imbalance, lesions of cochlear nerve or cochlear receptors result in central or nerve deafness. Damage to vestibular division produces dizziness, rapid involuntary eye movements, nystagmus, loss of balance, nausea, and vomiting. So we work really hard to rehab this area when we work with cranial nerve exercises and vestibular rehab. Basically, neuro rehab uses this as a foundation. Glossopharyngeal nerve here, fibers from medulla leave skull via jugular foramen and run to the throat. The motor functions innervate part of the tongue and the pharynx for swallowing and provide parasympathetics, arrest and digest fibers to the parotid salivary glands. Note parotid, that OT, it means ear here, like your otoscope. You're going to look into the ear with an otoscope, OT. Par being next to it. So these salivary glands, if you go up to your ear and kind of rub your jaw like you haven't eaten in a little while, and then you bite down on something and you're like, ah, sometimes that little spot hurts a little bit. That's the parotid gland secreting saliva. Maybe there's a stone, maybe you just haven't eaten in a while and just get the juices going. That's parotid. Sensory functions, fibers conduct bitter taste, bitter back 9, and general sensory impulses from the pharynx and the posterior tongue, and impulses from carotid chemoreceptors and baroreceptors. So checking in on oxygen indirectly by checking in on carbon dioxide of the blood, and then blood pressure as well. So how much oxygen is getting to the brain and how much pressure is bringing that oxygenated blood to the brain is the idea here. Glossopharyngeal nerve kind of overview here. So origin and course. Fibers emerge from the medulla and leave the skull via jugular foramen to run to the throat. Function, it's a mixed nerves that innervate part of the tongue and the pharynx, provide somatomotor to and carry proprioceptive fibers from a superior pharyngeal muscle called stylopharyngeus, which elevates the pharynx in swallowing, provides parasympathetic motor fibers to parotid salivary glands. Some of the nerve cell bodies of the parasympathetic motor neurons are located in what we call the otic ganglion. There's that OT again. Sensory fibers conduct taste and general sensory, touch, pressure, pain. Impulses from the pharynx and the posterior tongue, from chemoreceptors in the carotid body, which are monitoring oxygen via that indirect monitoring of oxygen via CO2 monitoring levels in the blood and help regulate respiratory rate and depth, and from the baroreceptors of the carotid sinus, which is monitoring blood pressure. Sensory neuron cell bodies are located in the superior and inferior ganglia. Clinical testing, check for position of the uvula, the little hang down thing in the back of your throat. Check for gag reflex. Don't do that though with your patients. People think we're weird enough. Don't gag your patient. And swallowing reflexes. Ask subject to speak and cough. You're already talking to them, so I think we're okay with that. Test posterior third of the tongue for taste. You could if you really needed to. I've never done it. Homeostatic imbalance. Injured or inflamed glossopharyngeal nerve impairs swallowing and taste. So if they're having troubles with swallowing, this is going to be an occupational therapist, usually doing something in the hospital or a nursing home setting, or with the elderly or stroke patients. So not usually what we do as chiropractors, but it's good to know. Here's the bitter back 9, so it's a golf reference. I'm not a golfer. But I guess you do fine on the first 9 holes, and then you just lose it in the back. So that's where that comes from, bitter back 9. So 7 is sweet, salty, sour. Cranial nerve 7 is responsible for the anterior 2/3 of the tongue. The back 1/3 is bitter. See the bitter valley back there, or valate. That is for bitter. So it's part of the gag reflex. So usually things that are bitter have a higher incidence of being poisonous. It hits the back of that back valley, valate there, and then cranial nerve 10 gets instigated by that, and then that's how you throw it back up. Cranial nerve 9, afferents, general sensory, again, posterior 1/3 of the tongue. Palatine tonsil, soft palate, Tympanic membrane, the carotid sinus and body again. Okay, we're pretty good at that. Motor, stylopharyngeus, parasympathetics, parotid, and otic. Okay, so parotid gland via the otic ganglion, and there's a nice picture of it there. Pause at any of these areas where you like the pictures and hang out with them for a little while. Good, so loss of taste, ipsilateral loss of gag reflex, so you poke at one side and you don't get a gag reflex, you poke at the other side and you do. Glossopharyngeal neuralgia, algia again just means pain. Cranial nerve 9 nuclei, so this is going to be GSAs, GVA, SVA, SVE, GVE. So GSA, spinal trigeminal nucleus. So remember, trigeminal is kind of all over the place. So it's more like a tract here. GVA and SVA, solitary. And then SVE, nucleus ambiguous. Remember, ambiguous is 9 and 10. GVE, inferior salivary nucleus. So superior was 7, inferior is 9. S for S, superior 7, and then inferior salivatory or salivary nucleus. It makes sense that 9 would have to do with saliva as well because it's bitter. And then I highlighted it in yellow over there on the picture for you. Cranial nerve 9 branches. You can see the picture over there, and we see tympanic, stylopharyngeal, pharyngeal, lingual, and carotid. So just kind of go off of what the word part means. Okay, so tympanic, tympanic membrane, eardrum area. Stylopharyngeal, okay, stylopharyngeal, pharyngeal, lingual is tongue, carotid down to the carotid body, carotid sinus area. Moving on to cranial nerve 10, vagus nerve. Vagus means wanderer. So Las Vegas, the wanderers, they were just wandering out in the desert and decided to build a city there. So cranial nerve 10 wanders all the way down to the internal organs. It's the only cranial nerve that extends beyond the head and neck region. Remember, some are going to go down into the neck, but this is going to go past that area. Fibers from the medulla exit the skull via the jugular foramen. Most motor fibers are parasympathetic fibers that help regulate activities of the heart, lungs, and abdominal viscera, so our internal organs. Sensory fibers carry impulses from the thoracic and abdominal viscera. Baroreceptors, chemoreceptors, so blood pressure, and then the chemistry of the blood being checking specifically for oxygen via CO2. And taste buds of the posterior tongue and pharynx, so it's going to get involved in taste as well. So this slide here, at the previous slide I explained the origin and course. So let's look at function. Mixed nerves. Nearly all motor fibers are parasympathetic efferents, except those serving skeletal muscles of the pharynx and the larynx involved in swallowing. Parasympathetic motor fibers supply heart, lungs, abdominal viscera involved in regulating heart rate, breathing, digestive system. Transmit sensory impulses from the thoracic and abdominal viscera from the aortic arch. Baroreceptors for blood pressure, carotid and aortic bodies for chemoreceptors for respiration. Taste buds on the epiglottis also carries general somatosensory information from small area of the skin on the external ear. We looked at the ear picture before. It's kind of fascinating how all the cranial nerves, not all of them, but many of them come together at the ear. It also carries proprioceptive fibers from muscles of the larynx and the pharynx. So clinical testing, as for cranial nerve 9 and 10, they're tested in common. So both are going to innervate the throat and the mouth and part of that gag reflex. But again, please don't gag your patients. Homeostatic imbalance, since laryngeal branches of the vagus nerve innervate nearly all muscles of the larynx or the voice box. Vagal nerve paralysis can lead to hoarseness or loss of voice. Other symptoms are difficulty swallowing and impaired digestive system motility. The parasympathetic nerves are important for maintaining the normal state of visceral organ activity. Without their influence, the sympathetic nerves, which mobilize and accelerate the vital body processes and also shut down digestion, would dominate. Aortic stretch receptors, good. I like this table to explain the vagus nerve's many functions here and what's going on. So let's look at it. Vagal component on the left, associated nucleus in the middle and colored there, and then innervated structures on the right. If you look down at the picture, you can see where those areas are as well. Note the inferior olivary nucleus. We always know we're in the medulla if we can see that area there. Okay, so the left side, the vagal component being parasympathetic, so the dorsal vagal nerve, that's going to innervate the autonomic ganglia of the thorax and the abdomen. The motor component, so the nucleus is ambiguous, and that's pharynx, larynx, and palate, so moving the throat, the voice box, and the palate. Viscerosensory, so viscera tells us we're looking for internal organs here. And so we're looking at the solitary nucleus, and that's going to be pharynx, larynx, and esophagus, thoracic and abdominal viscera. Chemosensory is also solitary nucleus, and it's taste buds of the epiglottis. So chemical reception is how we get the concept of taste. So chemoreceptors, taste. The next one down, somatosensory spinal trigeminal nucleus. So it's going to use the spinal trigeminal tract and nucleus here, as do many other aspects of our cranial nerves. And then the innervated structures are that outer ear canal and the pinna and the dura. And so it makes sense to me to use the ear in order to influence the vagus in order to influence the dura. So this helps me kind of make sense why auricular acupuncture works so well. Here's a nice picture. You can see it's kind of color-coded here. You can see dorsal vagal motor nucleus in blue in the center area there. You can see the squiggly lines of what looks like a dentate type of nucleus, but that's the inferior olivary complex. And then just the actual structure of the medulla, that midline area is the pyramids. And then what else are we looking at here? We can see the spinal nucleus of the trigeminal nerve, and that's that kind of blue pathway on the right, and then we can see the nucleus subtractus solitarius, that's the green pathway next to it. You can see the different ganglia. You can see if you're coming out to the left there, we can see vagus, okay, so cranial nerve 10, and then you can see the superior vagal ganglion and the inferior vagal ganglion. So what do we know about ganglia? They are the cluster of cell bodies. So kind of a nice picture, kind of pull it all together. That space in the back there, that is the fourth ventricle. So, cranial nerve 10, parasympathetic innervation to the heart to slow the heart rate. A nice little trick you can do with this as well is you can kind of press on the eyes. That's why going upside down is such a relaxing pose in yoga. So any pressure on the eyes will kind of slow our heart rate down, and parasympathetic innervation here to our vagal nerve. You can do a little carotid body sinus massage in an emergency situation as well. Well, they'll use that. So people have pain in the stomach, area of the cricothyroid, touch from the larynx, stretch receptors from our aortic arch, innervation to increase peristalsis or the movement of the digestive tract, and large food bolus passing through the pharynx and the larynx. These are all going to stimulate the cranial nerve 10 vagus. So you can look over to the picture there, you can see the food bolus, and I put in a slide there that shows a stricture and under a barium swallow there. Kind of interesting. Branches, so we have the auricular branch, so auricular being ear, and the superior ganglion associated with it. Pharyngeal is associated with inferior ganglion. Then we have our superior laryngeal and the recurrent laryngeal. Sometimes when they do a thyroid surgery, they'll nick that recurrent laryngeal branch and they'll have voice problems from that, maybe a hoarse voice or maybe even worse, not being able to talk. We have a cardiac branch going to the heart, pulmonary going to the lung, esophageal going to the esophagus, and take a look at that picture on the right and pause it and kind of check it out. How the vagus nerve affects organ systems. So this one kind of brings it together for us. The heart, the liver. So heart, we went through that, decreases heart rate and vascular tone, kind of chills you out. So vagal nerve stimulators are kind of all the rage in the neuro world right now, and I find them the information quite fascinating. But we'll talk about that on another day. The liver, it's going to regulate insulin secretion and glucose homeostasis of the liver. So the liver has a lot to do with blood sugar regulation, so not just the pancreas as we know it. The islets of Langerhans, the beta cells, that's a mouthful of words, right? Beta cells of the islets of Langerhans of the pancreas are associated with diabetes, but we also want to look at the liver too, and liver stagnation, usually due to some sort of medications or alcohol or what have you. That'll cause blood sugar issues as well. The gut, of course, it's going to increase gastric juices, gut motility, stomach acid. So just think of what the parasympathetic system does here. Inflammation suppresses inflammation via the cholinergic anti-inflammatory pathway. This is one of the things that they're looking at with the vagal nerve stimulator, and the idea that it is like dampening TNF or tumor necrosis factor, which is inflammatory, and then for some reason stimulating IL-10, the anti-inflammatory aspects of that. So it's kind of interesting. Nerve stimulation. There's a lot of neat papers out there right now on that. Brain up and to the right there, so helps keep anxiety and depression at bay, opposes the sympathetic response to stress. Mouth, taste information is sent via 3 cranial nerves, so 7, 9, and 10. Vagus nerve is needed for gag reflex, swallowing, and coughing. Blood vessels decreases vascular tone, lowering blood. Vasovagal syncope. So vaso being blood vessel, vagal being cranial nerve 10, syncope being they're passing out basically. So what happens here is we might see mental or visual distress, visceral stress, orthostatic, like you stood up too fast, and we'll see a parasympathetic activation, nerve and fluid changes, and then a sympathetic withdrawal, causing hypotension. So orthostatic hypotension, where you stand up too fast and your blood pressure drops, and the heart rate drops, and then they pass out. So I saw this once in a gym one time, and the guy was lifting something way too heavy, and he just put everything he had into it, and the poor guy passed out. And I was not really near them, and the guy passes out, and his buddy just starts laughing at him, and I quickly come over, because that's what we do as, healthcare professionals, and the guy said that he does it all the time, so it's kind of like a party trick for him, and it freaked me out, but the other guy was fine with it, and the guy woke up and was just fine. So I'm sure there are way more severe cases of that. You could crack your head and such, but it's not as uncommon as you would think. So vasovagal syncope. Cranial nerve 9 and 10, you want to remember those when it comes to the gag reflex. So 9 is going to be more afferent concept there. Think of that bitter back 9. And then 10 is going to be more for the motility of it. Cranial nerve 10 damage, so your boards are going to ask you a question like this. So unilateral lesion, uvula deviates away, A for A there. So uvula deviates away from the lesion. So basically if there's a problem on this aspect here, you would see that picture over there where the uvula is kind of tilted to the side there. So it might not be a lesion, it might be they have a sore throat and it's swollen on one side as well. Okay? So that's where being a doctor can take some thought process here as well. Bilateral lesion, dysphagia, having trouble with eating. So see that phage in there, P-H-A-G. So see the word part for esophagus, that phage, right? Food regurgitating into the nose when swallowing. Dysphonia, so trouble speaking. So look at that phone aspect, P-H-O-N, of that word. Dys being difficulty and phone being speaking. So think about how you talk on a phone. That's how I remember that one. Superior laryngeal nerve, the cricothyroid, so they would maybe have a monotonous voice. Recurrent laryngeal nerve, all other intrinsic laryngeal muscles, so hoarseness, paralysis of vocal cords. That's what I was talking about with the thyroid surgeries sometimes. And then they could have aphonia, okay, if both superior and recurrent laryngeal are damaged. So this would be a lower motor neuron lesion, and here's a picture of that uvula again. Origin and course here for cranial nerve 11. Moving on to accessory nerve. Spinal accessory nerve is what you'll see it called sometimes. So it's unique. Look at the picture over there. So see all those yellow lines? It's coming from the bottom and then going up. Okay? So it's unique in that they form from rootlets that emerge from the spinal cord, not the brainstem. These rootlets arise laterally from the superior region, so C1 through C5 of the spinal cord. So it's important to know this when we are adjusting their spine, right? So when we're in this area, we're going to have an influence on cranial nerve 11. And so with any luck, we're going to influence the sternocleidomastoid and the upper trapezius. So it'll be helpful for us to help them relax, right? So check out your upper traps. They're probably pretty tight, right? And most people's are, and that SCM as well. So let's get back to this. Superior region C1 to C5 of the spinal cord, pass upward along the spinal cord, enter the skull as the accessory nerves via the foramen magnum, and then it's going to come out through the jugular foramen together with vagus nerve and supply SCM. Well, accessory nerve is going to supply SCM and upper trap. Until recently, it was considered to have both a cranial and spinal portion, but the cranial rootlets are actually part of vagus nerve, is what this author believes. This raises an interesting question. Should the accessory nerve still be considered cranial nerve? Some anatomists say no, but we say yes here. This is cranial nerve 11. We're just going with the fact that it's a cranial nerve. Others say yes because their origin is different from a typical spinal nerve and they pass through the skull. Function, mixed nerves, but primarily motor in function. Supply motor fibers to upper trap and SCM, which together move the head and convey proprioceptive impulses from the same muscle. So a lot going on with this cranial nerve 11. It's going to be part of that kind of drive your shoulder up into your ear to protect your neck and kind of flinch posture. Clinical testing checks strength of SCM and trap by asking the person to rotate their head and shrug their shoulders against resistance. Homeostatic imbalance, injury to one accessory nerve, causes head to turn toward the injured side as a result of SCM muscle paralysis. Shrugging that shoulder, the role of the trapezius muscle can become difficult as well. So we can see this is really just a kind of study slide here. I highlighted the foramen magnum there for you in the center, obviously, and then off to the side is that jugular foramen. And then circled C5 to show you how far down that cranial nerve will go, and to keep that in mind when you're adjusting them. This is the upper cross, lower cross picture that I like to bring things back to every once in a while. So talking about SCM and upper trapezius, you could see that that is part of the facilitated. So if you look at the upper cross syndrome, up top there and in the white area as opposed to the gray area, you can see facilitated on the upper right is upper trap and levator scap. And then on the lower part, the cross is the SCM and pectoralis. So facilitated being tight. So these areas are kind of, everything is always online to some certain degree, to some extent, but these happen to be kind of hypertonic most of the time, and that is one of the thought processes behind that is cranial nerve 11, and the stress response is dictating that. So it's really important to get at that stress response for our patients and for ourselves. So if you look at the opposite, the gray area there is the inhibited, so the deep cervical flexors. So tuck your chin and get tall through the spine. Inhibited on the other side, lower trap serratus anterior. So shrug your shoulders up and release them all the way back down. Okay, so that lower trap, releasing them back down, is going to be the antagonist to upper trap. Serratus anterior, that's the muscles kind of by the rib cage area. Not kind of, but they are on the rib cage area. And that's what we fire off when we do our chaturangas, or those kind of specialized push-ups. So that really helps with posture. And then again, tuck the chin for those deep cervical flexors. And then we get into the lower crossed syndrome when we talk about other stress responders, or we're sitting all day, things like that. But really I wanted to point out how that cranial nerve 11 correlates to that upper crossed syndrome. This is an interesting picture, I think, that points out cranial nerve 11 damage to an extreme. You can see where she just does not have an upper trap on the right side there. Cranial nerve 12, origin and course. As the name implies, hypo means below, glossal, tongue. So hypoglossal nerve serves the tongue. Fibers arise by a series of roots from the medulla and exit the skull via the hypoglossal canal to travel to the tongue. Function, mixed nerve, but primarily motor in function. Carries somatomotor fibers to intrinsic and extrinsic muscles of the tongue and proprioceptor fibers to the same muscles to the brainstem. Hypoglossal nerve control allows tongue movements that mix and manipulate food during chewing and contribute to swallowing and speech. Clinically test, ask your patient to protrude and retract their tongue. So stick out the tongue and then put the tongue back into the mouth and look to see if it is pushing off to one side or the other. Homeostatic imbalance, damage to hypoglossal nerves, causes difficulty in speech and swallowing. If both nerves are impaired, the person cannot protrude their tongue, can't stick out their tongue evenly, would be one side, but can't stick it out at all would be both. If only one side is affected, tongue deviates or points towards the affected side. Eventually paralyzed side begins to atrophy. So, gag, speech, medulla, it's GSE, it's intrinsic and extrinsic except for palatoglossus. Rootlets exit between the pyramid and the olive of that medulla, and the nerve exits via the hypoglossal canal. So, thinking about those extrinsic muscles, think of genioglossus, styloglossus, and hyoglossus. So think of hyoid. Right? So genio protrudes the tongue, styloglossus makes a trough for swallowing, and hyoglossus depresses the tongue. And palatoglossus is going to then elevate the back of the tongue during swallowing, but that's vagus. Okay, so vagus. Intrinsic muscles, superior longitudinal, inferior longitudinal, vertical, and transverse. Real easy that way, they're just directional. Cranial nerve 12 damage to an extreme here, so 12 is towards the area here, towards the lesion. Ask the patient to stick out the tongue and deviates towards the damaged nerve. Okay, so the one side, so the right side there is working, so it's pushing, but it's unopposed by the left side. So the left side's not doing anything in the picture here, and so it's deviating towards the that side. So think of like a shopping cart, and the one wheel isn't working. So if your left front wheel isn't working and the right one is, you're going to deviate towards that side. It's going to turn to the left. So again, this is the T for how to spot a stroke fast. Remember that it's face, arm, speech, time, tongue. So the mnemonic is fast. Face, have them smile. Arms, drift test, either supinate or pronate is going to tell us different things. Speech, is their speech slurred? And then T for time, to call 911, and it's also check for tongue deviation. So a little study slide here for you to keep straight trigeminal neuralgia from Bell's palsy, trigeminal neuralgia, cranial nerve 5, also known as tic douloureux. See how it's T, trigeminal, T, tic douloureux, and then Bell's palsy is facial nerve, so facial nerve or 7. Here's the differential between the two. Bell's palsy, remember we were differentiating that between a stroke and Bell's palsy. A stroke is what we call eyebrow sparing. Bell's palsy is going to cause temporary partial facial paralysis in one side of the face. The pain is rarely present in the face, affects only one side. Maybe it's from cold exposure, dysfunction of the cranial nerve 7 here. So trigeminal neuralgia, cranial nerve 5, also known as tic douloureux. Quite literally pain in the trigeminal nerve or areas affected by trigeminal nerve. It's electric shock-like pain in part of the face. It can affect both sides. Certain factors cause to trigger it, so things like brushing the teeth, chewing, shaving, they don't really know sometimes. 1 or 2 or all 3 branches may be affected. This is a nice slide here from Duke University Medical School that is telling you the classification and location of the cranial nerve nuclei. So we're coming up on the part where I just give you a bunch of different tables to help you study. So it's not necessarily one table or another, it's just somebody's going to like one format and somebody's going to like another format, but they're all saying the same thing. So we need to know a rule of fours over there, medulla pons midbrain on the left, right? So you just divide it out into 4, and then you're going to know which cranial nerve is where, and then you would need to know where your cranial nerve nuclei are as well. Another study slide here, so some of the combined nuclei in the medulla, we're going to see afferents being trigeminal, spinal trigeminal 7, 9, and 10. General sensation from the external auditory meatus, so ear. Posterior 1/3 of the tongue, cranial nerve 9. Soft palate, pharynx, larynx 10. A solitary tract, not solitary at all, it's 7, 9, and 10. So we're looking at taste, visceral sensation from head, neck, thorax, and abdomen. Combined nuclei again here in the medulla, so efferent this time, nucleus ambiguous, 9 and 10, A-N-T. Motor to the branchial muscles. Inferior salivatory or saliva, right? So 9, inferior 9. 7 was superior, remember. So 9, preganglionic parasympathetic to parotid gland. Dorsal motor nucleus is 10, preganglionic parasympathetic to smooth muscle and glands of the pharynx and larynx, so throat and voice box. Preganglionic parasympathetics to thoracic and abdominal, and you can see the picture off to the right. Nice little chart here talking about parasympathetics. So 3, 7, 9, and 10, cranial nerves, 3, 7, 9, and 10, and their parasympathetic correlations here. So you can look at this chart to help you study that as well, kind of quiz yourself. This is a really nice chart as well, and I put the citation at the bottom there, and you can check that out. So again, it's cranial nerve, name, part of the central nervous system where it emerges from. Hey, just think about your rule of fours. And then function, sensory motor both, and then general distribution. This is just another study slide, so if it helps you, cool. If not, you don't have to look at it if it's overwhelming. Just study it in the other ways that you like, maybe through the pictures. But some people like tables and like to have it all in one spot, and you can kind of quiz yourself. So the cranial nerve, what are they? What fibers are they? Structures, innervated, function, and then the brainstem nucleus associated with it. Good job, you made it to the end. This is the heftiest chapter that we have, so great job sticking with it. Go check out your Bright Space quiz for chapter 12. Look at your lab link for the week and do that quiz as well. Make sure you're messaging me with any comments, questions, or concerns. Let me know if something's not working for you and how I can help. I'm here for you. Don't forget to just message me with anything that you need, okay? All right, I'll see you in the next chapter. Good job. Keep it up.